Hello everyone and welcome back to this next session of radiology in ENT. Since we are seeing a lot of image-based questions as one of the primary topics in the examination, radiological aspects are very important, come from the ENT point of view. So you need to know some common radiological images that are usually asked in the examination and some common pathologies in ENT that you identify with radiological signs. So let's begin this chapter on radiology in ENT. So first of all, when we talk of radiology, we always begin with X-rays. So we start with the X-rays of the paranasal sinuses. There are different views, but we will talk of the commonly used ones. The first one that you see here, the image is showing you the chin up position. So whenever there is a chin up position, we call this as occipitomental view. So chin up is nothing but your occipitomental view. This occipitomental view is also called as Waters view. So what is it also called as? It is called as Waters view. This is the best view for which sinus? This is the best view for viewing the maxillary sinus. So it is the best view for your maxillary sinus. So this view, chin up position, is called as occipitomental view, also called as Waters view, which is used for the maxillary sinus. But this is not exactly Waters view, what you see here in the image. Why is this not Waters view? Because you see the mouth is open. So in Waters view, the mouth is closed. But if we have Waters view and the mouth is open, what do we call that view as? Waters view with mouth open, we call this view as Pierre's view. So the view where you have mouth open, we call it as Pierre's view. So Pierre's view, Waters view are similar, except that the difference is in Waters view, the mouth is closed. In Pierre's view, the mouth is open. Now, Waters view is the best view for the maxillary sinus. So Waters view is the best view for your maxillary sinus. So reverse W, you get M. So Waters view is the best view for your maxillary sinus. Whereas Pierre's view is the view used whenever you want to visualize the sphenoid sinus. So when the mouth is open, through the open mouth, what we see is your sphenoid sinus. So Pierre's view is for your sphenoid sinus. So I hope you got two views. The first one is called as the Waters view. The second one is called as the Pierre's view. Occipitomental view, mouth closes. Waters occipitomental view with mouth open is your Pierre's view. So this was the first view of your paranasal sinus. Now let us go to the second view. Now if you see the occiput is bending downwards or chin down position, we call this as occipitofrontal view. So Caldwell's view is nothing but your occipitofrontal view. So occipitofrontal view is your Caldwell's view. Now in your occipitofrontal view or Caldwell's view, which sinus can you see? The sinus that is of interest in this view is going to be your frontal sinus. So Caldwell's view is used whenever you want to visualize the frontal sinus, whereas Waters view is used whenever you want to visualize the maxillary sinus. So these are two common views that we use in terms of maxillary and frontal sinus. Now let's look at the third view. The third view here is called as the lateral view. So if we take a parasagittal view or the lateral view, what sinus are we interested in? So this parasagittal view will give us mainly the understanding of the pneumatization pattern. How much is the sphenoid sinus pneumatized or air-filled? That pneumatization pattern of the sphenoid sinus is understood by lateral view. So sphenoid sinus pneumatization is understood by lateral view. Can we see only sphenoid sinus? Can we not see other sinuses? Of course not. You can see all the sinuses. You can see this is your frontal sinus, these are your ethmoid sinus, this is your maxillary sinus. We can see all the sinuses, but it's the best view to understand what? It is the best view to understand the pneumatization of which sinus? Pneumatization of sphenoid sinus. So this is about your lateral view. Now let's see some of the pathologies. Now let us understand certain landmarks before we go to the pathologies. So if you see this view, you know this is the occipitomental view or chin up position and it is showing you maxillary sinus. Okay, so this is your right maxillary sinus. This is your left maxillary sinus. Now, whenever a sinus is air filled, how does it appear? An air filled sinus will appear black. But if you see this sinus here, does it appear air filled to you? No, it appears hazy, it appears grayish. So what does it indicate? It indicates some pathology or a disease. Usually, if because it's in the sinus, we attribute it to sinusitis. So here we see that the right maxillary sinus is hazy. So what will your diagnosis be? It is going to be sinusitis. But let's have a look of other structures around it as well. So do you see the nasal septum here? Yes, it's partially deviated, not completely, but it's fine. There is a deviated nasal septum. This what we see here is the lateral wall of the nose. So is your lateral wall of the nose fine? Yes. Do we see air in the nasal passages? Yes. Do we see any disease there? No. We don't see any haziness. We see as a dark shadow or a black shadow, which means that the nasal cavity is healthy. This is probably a case of right maxillary sinusitis. So your diagnosis would be right maxillary sinusitis based upon the X-ray that has been given to you here. Because rest of it seems okay with deviated nasal septum can be added to your diagnosis. So right maxillary sinusitis with DNS can be your answer. Okay, now let's go to the next image. Now if you see this image, let us again start with landmarks one by one. So first of all, you are not able to see the septum completely, partially, it's pushed. Second thing, what about the nasal cavities? So if you see, this is your right nasal cavity, this is your left nasal cavity. Clearly you can see that right is air filled, left is hazy. So we can understand that right and left are not the same. There is some pathology in the left nasal cavity, it is diseased. Now if you see, this is the right maxillary sinus and this is your left maxillary sinus. Yes, right maxillary sinus is air filled and the left maxillary sinus is hazy. Now what is the diagnosis going to be here? There is haziness not just in the sinus but also into the nasal cavity. So when you have hazy sinus plus nasal cavity and you are noticing that this haziness is unilateral, all of this is only unilateral on one side, then your diagnosis usually will shift to antrochoinal polyp. Again, this is one of the differential diagnosis. We have to correlate this with the history, clinical examination and the other findings, the symptoms of the patient. So we are not going to conclusively tell that this is antrochoinal polyp, but typically we know that antrochoinal polyp originates from the maxillary sinus and goes to the nasal cavity. From there it goes posteriorly to the choana. We know that information. It is unilateral. Haziness of maxillary sinus and nasal cavity should prompt you to AC polyp. But can this be only AC polyp? No, it can be inverted papilloma, it can be maxillary sinus carcinoma. So it can be any of these. We have to correlate this with our history and our clinical examination. Okay, so this is the image showing you haziness not just of the sinus but also of the nasal cavity. Now let us go to this image. What do we see here? We see that the right maxillary sinus is hazy, the left maxillary sinus is well aerated. You see, this is the nasal cavity, which seems okay. The septum is fairly in the midline and the nasal passages are air filled because they are appearing blackish. Okay, so what is the thing that we are seeing? We are seeing that there is right maxillary sinus which is hazy, but there is something that is pointing to you very strongly. Do you see there is some very important structure over here? What is it? It is tooth. So the presence of tooth in the maxillary sinus with haziness, you should think about a dentigerous cyst. So you should think about what? A dentigerous cyst. So you have the cyst that has got impacted into the lateral wall or the sinus, and from there is a cystic transformation. The presence of tooth with haziness should prompt you to a dentigerous cyst. Now let us understand the CT scans, because they can ask you, they can point your structures in the examination and ask you about CT scans. So when we take a CT scan, we always go from anterior to posterior. So you can see we take an anterior cut, then we go 2 mm, 3 mm and take posterior cut. So the first cut will be the most anterior and the last cut is going to be the most posterior. So when we are starting with the anterior most cut cut, what are we going to see? We are obviously going to see the nasal cavity or the nasal bone structure, the frontal sinus, because that's the most anterior one. So in the anterior cuts, you can see this is the cartilaginous portion of the septum. You can see the frontal sinus. So the frontal sinus, the cartilaginous portion of the septum, and you can see here the nasal bones are coming into view. So these are the structures that you see in the anterior most part. So frontal sinus, nasal bone, cartilaginous portion of the septum, of course lateral nasal wall with the cartilages, but we are not so much interested in the structures of those on CT scan. We are interested mainly on the nasal bone, the septum and the frontal sinus when we are talking of the anterior cuts. Now as we keep going posteriorly, we will keep focusing on these structures one by one. So if you see in the next cuts, we still don't have maxillary sinus under vision. We don't have in the lateral wall any turbinates under vision. We have only the nasal bones that are still under vision, and we can see some portion of the septum becoming bony portion of the septum being visible. So in the anterior part, what we are seeing, I have clarified. Now let us see as we keep going further about 3-4 cuts posterior. You can see the inferior turbinate coming into view. You can see the septum, which is bent with a deviated nasal septum. You can see the frontal sinus is going to slowly disappear. So you can see the frontal sinus is going to disappear, but what is appearing? Your maxillary sinus is appearing. So as your frontal sinus disappears, what sinus keeps appearing? Maxillary. So we are going from front to back. So this is your frontal sinus and this is your maxillary sinus. What we have under view is only inferior turbinate in the nose and the septum in the nose, and we are going to see the end of frontal sinus soon and the beginning of the maxillary sinus. So again, this is your maxillary sinus, this is your septum, this is your inferior turbinates. Now that your frontal sinus has ended and you are able to see the maxillary sinus, before the appearance of middle turbinate. So in this cut we can see the inferior turbinate. Some portion of the middle turbinate probably seems to have appearing, but it has not appeared yet. So before the appearance of middle turbinate, when we see an air cell, what do we call that air cell? That is the anterior most ethmoidal air cell. We will call it as agar nasi. So what will we call it as? Agar nasi, the anterior most ethmoidal air cell. So you should be able to see this air cell before the appearance of middle turbinate. Now as we go to the next cut, you can see the middle turbinate coming into view. Now the air cell that you will see is going to be your bulla ethmoidalis. So what is bulla ethmoidalis? The biggest ethmoidal air cell is your bulla. The anterior most is your agar nasi. Then we keep focusing on to the nasal cavity, on to the maxillary sinus, on to the ethmoidal air cells, and we keep going posteriorly. Now as we keep going posteriorly, we see that there is a transition from the ethmoidal air cells that you see to the sphenoid sinus. So what we are able to see now? The sphenoid sinus. So we see there is some disease in the right side of the sphenoid sinus. So first we saw frontal, then we saw maxillary, then we saw ethmoidal air cells coming into view. All these air cells that you see are your ethmoidal air cells, and these ethmoidal air cells we will see continuing posteriorly into sphenoid sinus. So basically when we see a CT scan, the aim is to look for what are the structures that we aim to look at. The first and foremost, we aim to look at the septum. The second thing, we aim to look at the paranasal sinuses. We aim to look at the lateral wall of the nose with turbinates, and we'll try to look for any abnormalities in the nose and PNS and the adjacent structures. So from a UG point of view, if you are able to recognize that this is your maxillary sinus, medial to your eyes is your ethmoidal sinus, posteriorly we have the sphenoid sinus, this would be sufficient to answer a question on a CT PNS, and usually they will mark maxillary or the frontal or the ethmoid or the sphenoid and ask you questions on that. Okay, so I think a basic CT reading is understood by all of you. Let us go and see some pathologies also. So if we see the scan, we see this is our nasal septum. So this is the nasal septum. We see this is your inferior turbinate. This is your middle turbinate. But you see on the opposite side, the middle turbinate has become air filled. So whenever you get a air filled middle turbinate, what do we call it as? An air filled middle turbinate is called as concha bullosa. So what is it called as? It is called as concha bullosa. So concha bullosa is nothing but an air-filled middle turbinate or a pneumatized middle turbinate. So we call that as a concha bullosa. It is typically known to cause headaches, and that is why concha bullosa becomes very important in patients who are presenting to you with headache. Okay, now let us see the air cells. Now, if you see, there are some air cells which are present medial to the eye or in relation to the medial wall of the orbit. What air cells they will be? They will be your ethmoidal air cells. So, ethmoidal air cells are present in relation to which wall of the orbit? They are present in relation to the medial wall of the orbit. That is the lateral extent. Medial extent, do you see the extent between the middle turbinate? Yes. So you can see that they are extending from the middle turbinate medially and the medial wall of the orbit laterally, and in between them we have these air cells. We call these as ethmoidal air cells. But do you see there is one ethmoidal air cell which is present in relation to the floor of the orbit? Inferomedial to the orbit, inferior to the orbit and medial to the orbit? Yes, we call such a cell as Haller cell. So what do we call it as? A Haller cell. So what is a Haller cell? An ethmoidal air cell which is present inferomedial to the orbit or which is in relation to the floor of orbit. We call this cell as a Haller cell. So ethmoidal air cells are normally in relation to which wall? They are in relation to medial wall. But if you have one ethmoidal air cell which is not in relation to the medial wall but is in relation to the floor, we call it as a Haller cell. So I think this is clear to everybody. Okay, now let us see some of common other pathologies adjacent to the nose and paranasal sinuses. I think everybody would know this. You can see clearly there is a defect in the floor of the orbit and the contents of the orbit are herniating downwards. So whenever you have herniation of the orbital contents into the maxillary sinus, we call that sign as a teardrop sign. So this sign is called as teardrop sign. And where do you see this teardrop sign? This teardrop sign is seen in a blowout fracture. What is a blowout fracture? It is the fracture of the floor of orbit. So whenever we have a fracture of the floor of the orbit, we call it as the blowout fracture. Now let us understand some of the ear views. So far we've understood the views related to your nose. Let us see some of the views in relation to your ear and for the mastoid. So if you see, there is a sagittal plane that we have taken and there is a 15 degrees cephalocaudal angulation. So if you take a view like this with 15 degrees angulation like this, meaning cephalocaudal, this angulation is 15 degrees, we call this view as Law's view. So in Law's view, how much is the angulation? This is very important, 15 degrees, because if it changes to 30 degrees, if you see here, the same lateral view or sagittal view but 30-degree angulation, then you call it as Schuller's view. So if there is only 15-degree angulation, we call it as Law's view, but a 30-degree angulation, we call it as Schuller's view. So if you see here in the X-ray of the ear, what are the structures that we see? We can clearly identify the external auditory canal. So you can identify the external auditory canal. Behind that we have this air cells, which is your mastoid air cells. Anteriorly you can see the TM joint. So we are able to appreciate the canal, we are able to appreciate the mastoid air cells, we are able to appreciate the pneumatization pattern. We are able to see how much is the mastoid hazy and how much is the mastoid air-filled. Here you can see it is air-filled, you can see numerous septa. So there is one septa like this. So there are septations between the air cells. So these septations can be understood, pneumatization can be understood. And if there is a disease, it won't be air-filled or it won't appear black, it will appear hazy. So haziness will tell you about mastoiditis or a disease in the mastoid. But here it is air-filled, so we are able to understand that this is a normal mastoid, does not have any pathology. Now let us go to Schuller's view. Schuller's view is the same view, 30 degrees cephalocaudal angulation. This is your external auditory canal. This is your mastoid air cells. We can see it is air filled, it is black, and there is no disease. If there is a disease, it would appear hazy. So Schuller's view, what is the angulation? 30 degrees. The only difference between Law's view and the Schuller's view is the angulation. Now let's see some common ENT pathologies in terms of radiology. So if you see here, there appears to be some mass coming from the coming from the maxillary sinus, actually going from there to the nasal cavity, and from there it is going into the nasopharynx. So we can see that there is some haziness, a grayish mass that is going posteriorly towards the choana. But what you can appreciate here very clearly is there is a column of air, this black column of air between the mass and the posterior pharyngeal wall. So this column of air that you see between the mass and the posterior pharyngeal wall, this column of air I am talking about, that column of air, we call that sign as crescent sign, also called as dot sign. So this is called as crescent sign, also called as dot sign. And where do we get this crescent sign or dot sign? We get this crescent sign or dot sign in an antrochoanal polyp. So antrochoanal polyp will show you this shadow that we have between the mass and the posterior pharyngeal wall. So this sign we call it as crescent sign or dot sign seen in an antrochoanal polyp. Let's see some other pathologies. Now if you see, this is a lateral view of the neck showing to us some very important structures. So first and foremost, if you see, there is a blackish column of air. So this blackish column of air indicates your respiratory tract, meaning your larynx and the cervical trachea. So begins from the nose, nasopharynx, larynx and the trachea. This column of air we call it as your respiratory tract. Behind that you see a greyish shadow. This greyish shadow in front of vertebra, what do we call that as? That is your digestive tract, hypopharynx leading to esophagus. So we have the respiratory tract in the front and we have the digestive tract behind. So this column of air that we see here belongs to your respiratory tract, meaning this is your nasopharynx, this is your oropharynx, this is your larynx, and this is your trachea. So this is all of your respiratory tract. Now this grey shadow that you see in front of vertebra, this is your hypopharynx continuing as esophagus. So that is a part of your digestive tract. So all of you, if I zoom in, you are able to appreciate the grey shadow and the blackish shadow. So that is the respiratory and the digestive tract. Behind that you are going to see the vertebral bodies with the vertebra. So this is what you see normally. Now let us see what happens in a pathology. What is it that you see? Obviously anteriorly the respiratory tract seems fine, except that you are seeing some narrowing over here. But what is happening to the greyish shadow or the prevertebral soft tissue shadow? Do you see there is a widening? Yes. So that widening of the prevertebral shadow is suggestive of something. So widening of prevertebral soft tissue shadow. So widening of the prevertebral soft tissue shadow is suggestive of an abscess. Which abscess? A retropharyngeal abscess. So in a retropharyngeal abscess, you will see that there is a widening of the prevertebral soft tissue shadow. Now here you are going to identify that is this actually widening or is this narrowed? What is that parameter that will tell us this is wide or not? For that you have to take the size of the body of vertebra. So if you see, this is the body of vertebra, correct? Now if I compare this with the size of the body of vertebra, we see that this prevertebral soft tissue shadow is at least 2 times or more than the size of the body of vertebra. then we say that it has got widened. So when do we say it has widened? The gray shadow should be more than 2 times the size of the body of vertebra, then only we say there is widening. And when we see widening, we usually think of a retropharyngeal abscess. It could also be a prevertebral abscess, but we cannot tell conclusively only on an X-ray. We have to do further investigations with a CT and an MRI to confirm the same. Now you will see that there is straightening of the cervical spine. Normally if you see, cervical spine has a curvature, a lordosis. But here do you see there is straightening of the cervical spine? Yes. So straightening of the cervical spine is another very important feature that will suggest to you that this is a retropharyngeal abscess. So widening of the prevertebral soft tissue shadow, straightening of the cervical spine, and sometimes the presence of air bubbles, all these are features of a retropharyngeal abscess. Normally you don't see all of that. You will see that the prevertebral soft tissue shadow is less than the size of the body of vertebra. There will be a cervical lordosis or a curvature, and there will be no air bubbles. But the presence of the prevertebral soft tissue shadow, and if there is widening of the shadow and you see air bubbles and you see that there is straightening of the cervical spine, it must prompt to you that it is a retropharyngeal abscess. Let us see the sign, a common sign which is repeated very commonly in the examination. You can see there is swelling of the epiglottis. It is swollen and it looks like the thumb. So this sign we call it as thumb sign. And where do we get this thumb sign? I'm sure all of you know this because it's a repeat common PYQ. This thumb sign is a feature of acute epiglottitis. So in acute epiglottitis, you get this sign which is called as your thumb sign. So thumb sign is a feature of acute epiglottitis. Now let us see this sign, again a very common sign. Now if you see, this is the air column of a child which seems more or less normal. But if you see the air column of a child here, you can see there is narrowing at the region of the subglottis. So you can see that here it is narrow. This sign we call it as steeple sign. So what is steeple sign? It is narrowing of the subglottis resembling the steeple of the church. So we have the steeple of the church, right? So narrowing of the subglottis resembling the steeple of the church, we call it as steeple sign, and steeple sign is seen in croup. And what is croup? Laryngotracheobronchitis is called as croup. So laryngotracheobronchitis is called as croup, and this sign is called as steeple sign. Now let us see this image. You are able to see there is a radio opaque shadow in the neck and it appears circular or spherical. So this is definitely a foreign body in the throat. Typically you will think of a coin. But on an anteroposterior view, do we understand that this is in the respiratory tract or the digestive tract? I have showed you two columns, right? A black column and a grey column. On an AP view, can we identify that is it in the respiratory tract or the digestive tract? No. So we have to take a lateral view. So when we take a lateral view X-ray, we can see anteriorly this is your air column. Behind that we have the soft tissue column. In which column do you see is the foreign body located? It is located in your soft tissue column, which means it's a part of your digestive tract. It is not a part of your respiratory tract. So this entire column of air that you see, this is your respiratory column, and this column that you see is the digestive column. So where is the foreign body located? The foreign body is supposed here to be located in the cricopharyngeal sphincter. So the hypopharynx continues as esophagus below. So at this junction where the hypopharynx continues as esophagus, we have a sphincter called as the cricopharyngeal sphincter, and the foreign body seems to have got impacted in the cricopharyngeal sphincter. So now let us see some investigation that you are usually not exposed to or rarely seeing this investigation. So here what you see, this is called as a xylography. So xylography is an investigation that you do to understand if the ducts of the salivary glands are patent or not. Is there any obstruction to the flow of saliva from the ducts of salivary gland. So you can make out this is your parotid gland because it is present below the zygoma near the angle of your mandible. You can appreciate that this is your mandible. So behind the mandible, below the zygoma, you are able to appreciate the gland is your parotid gland. Now we can identify the course of the duct of the parotid gland like this. So when we try to identify the course of duct of the parotid gland, we call that procedure as xylography. So you can see nicely the duct is patent. There seems to be no obstruction anywhere. So this is a normal xylography where we are seeing that the duct of the parotid gland is seeming to be patent and does not have any calculus, does not have any stone inside it. So this is your xylography. So what do we do in a xylography? We will cannulate the opening in the mouth because we know that the parotid duct opens at the upper second molar. So we are going to dilate it slightly with a dilator and then we are going to inject a dye. Once we inject the dye will go through the entire course of the duct and to the gland. Now once we inject the dye and then we take an X-ray, can we see the course of the dye on an X-ray? Yes, if it freely flows up to the gland, it means that there is no obstruction. But if you see that the dye is flowing to a certain extent and not flowing beyond, it means that there is an obstruction. This obstruction can be because of a calculus, it can be because of duct ectasia or for any other abnormality like a mucus plug. So to understand the ductal abnormalities of the salivary gland, we do a xylography. You can see here the duct at a certain point does not have that radio opaque density. It indicates that at this level the dye could not flow from the salivary duct. It indicates that there is an obstruction here. This obstruction can be because of mucus plug or a stone. So this is indicating a pathology where there is an obstructive pathology in the salivary duct. Okay, now let us see this X-ray. You are able to see this is the nasal bone and there is a fracture. So if you see here very closely, you see that there is a fracture. This fracture is a mildly displaced fracture. So this X-ray should give you that this is a diagnosis of the fracture of the nasal bones. Now very keenly you should see, only then you will be able to appreciate this fracture. So now I think you are able to appreciate here there is a fracture of the nasal bone. So when you are given this X-ray, you keep thinking here and there, you see frontal, ethmoidal, sphenoidal, maxillary. The diagnosis is a very simple thing which is nothing but the fracture of the nasal bones. Now let's see this investigation. This is a barium swallow. So what is a barium swallow? The patient is given a meal mixed in barium and then you take an X-ray. Now, if the food goes into the esophagus, from the hypopharynx to the esophagus, you will see that it's only in your digestive tract. But if there is a pharyngeal pouch or a Zenker's diverticulum, you can identify by the barium swallow where you can see that the bolus of food is going into the sac as well. So, barium swallow is showing to you what over here? It is showing to you a pharyngeal pouch, also called as the Zenker's diverticulum, which happens because of outpouching of the mucosa through the Killian's dehiscence. Now this investigation that you see is called as an angiography. So on an angiography, you can see that this is your common carotid artery, this is your internal carotid artery and this is your external carotid artery. Do you see there is playing, there is widening, there is separation? Yes. So this playing of the carotids, we call this as a sign. What is this sign called as? This is called as the Lyer's sign. So Lyer's sign is what? Splaying of the carotid, which is a feature of carotid body tumor, which is a paraganglioma. So Lyer's sign is seen in a carotid body tumor. So I hope everybody understood on angiography the Lyer's sign. Now let us see this radiological investigation, which is showing to you an air-filled swelling on the side of the larynx. So this is the region of your larynx, and on the side of the larynx you are seeing some blackish air-filled swelling. So this is the region of your larynx and air-filled blackish cystic swelling. What do we call this blackish air-filled cystic swelling? We call this blackish air-filled cystic swelling as laryngocele. So typically laryngocele is herniation of there is a air-filled cystic swelling of the saccule, which is a part of the ventricle of the larynx, typically seen in trumpet blowers, glass blowers, where the saccule will become air-filled and cystic on increase in the transglottic pressure, and on radiological investigation it will appear black with a swelling. So black with a swelling on the sides of larynx should prompt you for a laryngocele diagnosis. Now let us see some of the CT findings. Now if you see, this is the mastoids of the normal side and the opposite side. You are able to identify the middle ear of the normal side, and this is the middle ear of the opposite side. Why am I saying this side is normal and the opposite side is abnormal? So typically if you see this side, it is air filled, it is appearing black. Whether it is the mastoid or the middle ear, it is appearing black. Now in the middle ear, you are able to see a structure which looks like an ice cream cone. What is this ice cream cone? It represents your ossicle. Which ossicle? They represent your head of malleus and body of incus. So all these structures we are able to see. We are seeing the malleus, we are seeing the incus, we are able to see that the air-filled pneumatization of the middle ear, we are seeing air-filled pneumatization of the mastoid, which is why this side I am saying is normal. Now compare it with the opposite side. What is happening to the mastoid of the opposite side? Does it look air-filled and black? No, it is definitely hazy. So there is a disease in the mastoid. Do you see the middle ear? Does it appear hazy? Yes, there is haziness of the middle ear. But do you see the ossicles are intact? Yes, ossicles are intact and present. So haziness of the middle ear and mastoid, does it indicate to you usually a CSOM with mastoiditis? Yes, so you should think of a diagnosis of CSOM with mastoiditis whenever you get an image like this showing you the haziness in the middle ear and the mastoid. Now this is your inner ear that you see over here, which is present in the petrous part of the temporal bone. So that is your inner ear present in the petrous part of the temporal bone. Now let us see another image. Now this is your external auditory canal leading to the middle ear. This is your mastoid air cells. Now what is definitely understood by the image, you can see that there is haziness, so there is definitely mastoiditis. There is definitely mastoiditis. Now when we compare it to the opposite side is air filled, so we say that this is a left-sided mastoiditis. So this is right, this is left. So this is a left-sided mastoiditis because it is air-filled. Normally you see there are some septation between one air cell and another air cell. Yes, but do you see, is there septation or loss of septation? There is loss of septation in the mastoid air cells over here. So mastoiditis will present to you radiologically with haziness of the mastoid and loss of septation. So these are the features that you will see in mastoiditis. Now look at this image. It is showing to you a rehabilitation technique. Typically after doing a cochlear implant surgery, you want to have a check X-ray to understand whether the implant has gone correctly into the cochlea or not. So for that you do this X-ray, which is an X-ray showing you the cochlear implant. So these are your cochlear implants, the external component and the internal component. From the internal receiver, you have an electrode array. This electrode array is going into the cochlea. So you can identify the course of the electrode array. It is going into the cochlea. So to understand the positioning, whether it is functioning or not, we cannot understand. But positioning, is it done into the cochlea or not? We understand by taking this check X-ray. So this is a check X-ray of the cochlear implant patient showing to you the presence of electrodes inside the cochlea. Now let us look at this radiological image, a very interesting one, commonly asked questions on this image. So first of all, what is this structure that you see here? This is the image of, or this is the impression of internal carotid artery. Now at the posterior border of the mastoid, you have the sigmoid sinus. This sigmoid sinus continues as internal jugular vein. So you see this is the sigmoid sinus at the posterior border of mastoid, continues as internal jugular vein. Now you see this is your carotid impression. So this is your ICA. Now, are you able to appreciate there is a chunk of bone present here between jugular and the carotid? Yes, so there is a bone present between internal jugular vein and the internal carotid artery. But look at the opposite side. This is your carotid, this is your jugular. Do you see any bone or there is erosion of the bone? Yes, there is absence of that bone or erosion of the bone. So erosion of carotico-jugular spine. So whenever you see the erosion of bone between carotid and jugular, we call that sign as Phelps sign. So what is this called as? This is called as your Phelps sign. So what is Phelps sign? Phelps sign is erosion of the bone between the carotid and the jugular. We call this sign as Phelps sign. So erosion of carotico-jugular spine or the bone between carotid and jugular, we call this sign as Phelps sign, and this is typically seen in a tumor called as the glomus tumor. So where do you get this Phelps sign? It is seen in glomus tumor, which is a paraganglioma. So here what we see is a glomus jugular showing to you erosion of the carotico-jugular spine. So you are able to see on an MRI with contrast a typical ice cream cone appearance. So the presence of ice cream cone appearance on an MRI with contrast is suggestive of a tumor. Which tumor? I'm sure all of you know this. This is suggestive to you of acoustic neuroma, also called as a vestibular schwannoma. So typical appearance is ice cream cone appearance. So ice cream cone appearance should point to you that this is an acoustic neuroma or a vestibular schwannoma. Now here again a very important X-ray, typically in toddlers, in young children, you will see that there can be a foreign body in the nose. Why do we take a lateral view of the foreign body? Because we want to see is the foreign body anteriorly located or posteriorly located. Typically for a posteriorly located foreign body, you would like to do this under anesthesia because you want to protect the airway and also you don't want the child to move while removing it, because if you're trying to remove a posteriorly placed foreign body, there is a high possibility that the foreign body can get dislodged and enter into your airway and get aspirated. So to prevent that, you will do an endotracheal intubation, protect your airway and take out the foreign body without the child moving in a safer way to prevent dislodgement or aspiration. Let's see another very important scan, a radiological sign that we see. Now you see there is haziness of the maxillary sinus on both the side, haziness of the nasal cavity. So it could be a rhinosinusitis by all of you. Yes, but typically what are we seeing here? We are seeing areas which are dark grey and we are seeing areas which are light grey. And we are seeing certain areas which are black. Black is air filled, which is normal. But that dark grey and light grey, we call them as double densities. There are two different densities. So what do we call them as? Double densities. So you see there are areas which are having these double densities, and the presence of double densities is suggestive of a very important diagnosis. It is suggestive of allergic fungal rhinosinusitis. What does AFRS stands for? Allergic fungal rhinosinusitis. So in allergic fungal rhinosinusitis, you get this sign which is nothing but your double densities. So the presence of double densities should prompt you to the diagnosis of AFRS, allergic fungal rhinosinusitis. Now let us see one normal anatomical variation. This is your sphenoid sinus. But do you see here there is encroachment of the posterior ethmoidal cell into the sphenoid sinus? Yes, so when we have the posterior ethmoidal cell extending into the sphenoid sinus, we will call such a cell as an Onodi cell. So what is Onodi cell? It is the extension of the posterior ethmoidal cell into the sphenoid sinus. But what is very important, are you able to appreciate these structures over here? This is nothing but your optic nerve. So Onodi cell is in very close relation to the optic nerve. You can see within the cell the optic nerve present. So this is the CT scan showing to you the Onodi cell. So this is basically your sphenoid sinus, and in the floor of the sphenoid sinus we see two foramina. We are seeing this is the Vedian canal below. So this is your Vedian canal. and this canal above is your foramen rotundum. So we have foramen rotundum, we have the Vidian canal. So these are the other important structures that you should look for whenever you are seeing the sphenoid sinus. Below the sphenoid sinus, we have the nasopharynx. This is the pterygoid base with the medial pterygoid plate and lateral pterygoid space. So this is your pterygoid base with the medial pterygoid plate and lateral pterygoid plate, and we seeing the sphenoid sinus, optic nerve present superiorly. We have the foramen rotundum above and Vidian canal below. So these are the structures of your sphenoid sinus. Now let us see this investigation. There seems to be a dye coming all the way from your cranial cavity and tracking through a defect that we have, and through the defect it is seeming to enter the nose. So what is this investigation? Where we do a lumbar puncture, inject fluorescein dye into the CSF, and then that CSF stains the entire fluid around the brain and spinal cord, and that dye will now come through a defect which, if present in the base of skull, into the nasal cavity. We call this investigation as CT cysternography. So CT cysternography is the diagnostic investigation to identify active CSF leak, meaning you know it is CSF by understanding the beta 2 transferrin is positive, but actively from which site in the bone or break in the bone is the CSF coming from. To understand that active leak, we are going to do this investigation, where we can see the dye passing all the way from the cranial cavity. We see there is a defect, and from there coming into the nose tells us that definitely there is CSF leak with a defect here, and at that place we have to go and repair. So this investigation is called as CT cysternography. Let us see the next image showing you a fracture. So if you see there is a fracture of the mandible, the most common site of fracture is the subcondylar fracture. So this is the most common fracture of the mandible, where you see a subcondylar fracture. So this is the fracture of mandible. And what fracture is this? This is a subcondylar fracture. And if you have a symphysis menti fracture with fracture of the bilateral subcondylar region, so bilateral subcondylar with a symphysis menti fracture, we call it as a parade ground fracture. So in a parade ground fracture, we will have bilateral symphysis menti with bilateral subcondylar fracture. We call it as a parade ground fracture. Okay, so now let us see another fracture. You are seeing a fracture of a bone called as the zygomatic bone, and you are seeing there is a fracture at the zygomatico frontal suture, zygomatico temporal suture, and zygomatico maxillary suture, like a tripod. So this tripod fracture is suggestive to you of a zygomatic fracture. So zygomatic fracture or a tripod fracture would mean the same. So in a tripod fracture, what are you seeing? You're having three lines of fracture: zygomatico-frontal, zygomatico-temporal, and zygomatico-maxillary. So this is a fracture of the zygoma, and this fracture is called as a tripod fracture. Now if you see this, this is basically a chest x-ray, but what is it that you should look for? Here we are able to see that there is a tube. What is this tube? This is a tracheostomy tube. So typically when we are not sure whether the tracheostomy tube is there or not, is it in the false passage? So typically after having performed tracheostomy, if you want to confirm objectively the evidence of tracheostomy tube in its position in the trachea, you do an x-ray, not just AP view, you also do a lateral view x-ray that will tell you the position of tracheostomy tube, if it is present in its correct position in the trachea, or has it gone into another position between the skin and subcutaneous tissue, or below the strap muscles, or in a false passage. So to understand that, we will have to take this x-ray, and objective evidence of showing the tracheostomy tube to be in the trachea, not just the anterior posterior. Again, a lateral view x-ray also has to be taken. So that completes most of the important radiological images that you need to know for your examination. Whilst there can be many, but we have summarized most important information for you in one place, so that when you are going to examination, a quick revision of all of these images will help you to a greater extent. I would always say that once you have done this as for the first time, and when you're doing it as a second or third time, go it very quickly on 1.75x speed also. You should be able to look at the image and get the diagnosis and the related aspects of it in your mind immediately. So I'm hoping that you have understood the entire radiology well, and I'm hoping that you enjoyed this session. Wishing you lots of love and wishing you lots of good luck. Hoping to see you again in my next classes. Until then, take care and bye bye.